Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Standard Medical Notes. So, in the previous video, we were discussing about the topic of acute coronary syndromes and ischemia, and we have discussed this STEMI, what is STEMI, and how much ST elimination is required. What will be the evolution of STEMI, localization of the infarction part, and NSTEMI. What are the criteria of depression and STEMI, T-wave inversions? Okay, Wellens sign, that is nothing but T-wave inversion, symmetrical T-wave inversion, V2 and V3, that is Wellens and proximal left anterior descending artery stenosis, Q wave, what is pathological Q wave, and poor R wave progression, that is nothing but less than or equal to 3 mm amplitude of R wave in V3 lead. That was the theoretical part which we have discussed. And figure we have discussed this, why it is elevated and why it is depressed in STEMI and NSTEMI respectively. This is the progression part. Normally it is like this: hyperacute T waves. Okay, this is within minutes to hours, and then there will be ST segment elevation. This is in hours. Okay, this is in minutes to hours. This is hyperacute waves. This one is minutes to hours. Actually, I will zoom it in. Sorry, I will zoom it in. So this is in minutes actually, hyperacute wave, and this ST segment elevation is within minutes to hours. Then there will be development of Q wave. ST elevation Q wave is hours to 1 day, hours to 1 day, 1 to 2 hours, and ST elevation, then T wave inversion, then comes the T wave inversion, that is in days. Okay, then T wave recovery will be there, and there will be Q wave, that is in weeks to months. So previously the diagram was not good, so I replaced with a good diagram now. Important, this evolution is important. We just remember this evolution: hyperacute T waves, then there will be ST segment elevation, then development of Q waves, then inversion of T waves, then ST segment will come back to normal and T wave will be normal, but Q waves, pathological Q waves will persist. So this is in minutes, this is in minutes to hours, this is from 1 to 12 hours, and this is in days, and this is in weeks to months. Okay, we also discussed different type of T waves: normal T waves, the normal variant, hyperkalemic T waves, hyperacute T waves, biphasic T waves, post-ischemic and ongoing ischemic T waves, cerebral T waves, HOCM T waves, and perimyocarditis T waves. Okay, now we will continue. So now there'll be there'll be uh, equal to none theory, and more of diagrams and ECGs will be there. So we will understand better in this. So again, I'm discussing more of T waves, stressing more on the T waves because this is very important now. Okay, one point we should remember is we should differentiate between what do you call, the early repolarization pattern, where it is the early repolarization pattern T waves, hyperacute T waves, and this hyperkalemic T waves. These three T waves, the first we have discussed in the first on the above diagram, okay, which I have shown. So these three T waves we need to differentiate. Okay, we need to differentiate. See, in hyperkalemia there will be tall T waves. What is tall T waves? We will be knowing in the next diagram. Okay, so but the base is narrow and apex is pointed. That is hyperkalemic, and there will be no ST segment deviation. In hyperacute T waves, the base will be broad and apex will not be pointed, but it can be pointed. This is important point. Okay, normally it is not pointed. Okay, the main thing which is not differentiating between hyperkalemic and hyperacute TOS is the base. The base is narrow in hyperkalemic and the base is wide in infarction. Now here you can see again the base is somewhat not elevated TOS, we can say this as somewhat base is narrow. Okay, but you can see here concave ST segment elevation, and this is J point, irregular contour of J point. Where is the J point? J point contour is, so this early repolarization pattern, it has 3 to 4 different types of early repolarization patterns. Will be knowing in the coming figures. Okay, just remember we need to differentiate between hyperkalemic, hyperacute, and early repolarization pattern. What is the significance? Peak T waves means hyperkalemia, hyperacute means infarction. Okay, early repolarization pattern, previously they thought that it is only benign, but now they are thinking it as a risk factor. We have learned in the topic of cardiac chest pain what we have learned. So the early repolarization pattern is given 1 point there. If you remember the heart score in ECG, okay, in the ECG, the early repolarization pattern is given as 1 point, one risk factor. Okay, so when there is early repolarization pattern, think of risk factor. So early repolarization pattern is now it is a marker of increased risk of sudden cardiac death. Remember, early repolarization pattern is considered as a marker of risk factor for sudden cardiac death. Remember that point. So what are long T waves? Long T waves we are seeing in hyperkalemia and hyperacute. So when you say that as long, so remember, peak T waves are nothing but in the limb leads. You know what are the limb leads? Okay, 1, 2, 3 AVL, AVF, AR. So the amplitude should be more than 5 mm in the limb leads, and the amplitude should be more than 10 mm in the precordial leads. In the precordial leads. So 5 mm is nothing but one large square. Okay, one large square. 5 mm is nothing but one large square, and 10 mm is nothing but two large square. So you can see here this ECG, if you draw a point from, or you take it from here, this point. So this is more than 10 mm. I think this is a limb lead. Okay, this is more than 10 mm. So this is a tall T wave. Now whether it is hyperkalemic or hyperacute, so that you know by the base. See the base is broad. So these are hyperacute T waves. These are not hyperkalemic. These are hyperacute T waves. Okay. So that you should remember. In the limb leads, the amplitude should be more than 5 mm, and in the precordial leads, the amplitude should be more than 10 mm. Now we will see the patterns. See this ECG. So this ECG, what are you seeing? You are seeing tall T waves. Okay. You are seeing, sorry, you are seeing tall T waves. See the grossly you can see tall T waves everywhere. Tall T waves. So diffuse tall T waves you are seeing, diffuse tall T waves in the 2, 3. Okay, everywhere you are seeing. In AVR it is be inverted. So everywhere you are seeing tall T waves. That means it is hyperkalemic, because in infarction it will be in a pattern like inferior, anterolateral, lateral, posterior, right. Okay, that will be in a pattern. But in case of hyperkalemia, it will be diffuse hyperkalemic T waves. Now we will see the amplitude. See the amplitude in the limb lead. We will take the limb lead second. So in limb leads, the amplitude should be more than 5 mm. So you just draw a line here. Okay, so this is 1, 2, 3, 4, 5, 6. So 6 mm height. Okay, and the base is narrow. Base is narrow, and there you are not seeing any ST segment changes. So that you have found out. Now in precordial leads, what you should see, they should be more than 10 mm. Okay, they should be more than 10 mm. If you take it from here, okay, this is 2 mm, this is 5 mm, and this is again 2 mm. So approximately it is 10 mm only. Okay, so in the precordial leads they are 10 mm, or you see it more. See in V3 you can appreciate more better. Okay, see here, this is 5 mm, this is 5 mm, and this is 3 mm. So total 13 mm in the precordial lead. So that means this is hyperkalemia. Okay, this is hyperkalemic T waves. So if you are saying any dampening of P waves, because in severe hyperkalemia, what will be there? There'll be uh, dampening of the amplitude of P wave, and then there'll be widening of the PR interval, and then there'll be widening of the QRS complex, and then there'll be sine wave, and there'll be arrest. So just you are seeing here, you take again lead to rhythm strip. See, there is no there is P wave. See, P wave is there, and the PR interval from here to here, if you take, okay, 1, 2, 3. Okay, it is normal. PR interval is normal. PV is also there. So it is an early hyperkalemic. Maybe the mild to moderate hyperkalemia, you can say more than 6.5 milliequivalents, 6.5 to 7. This may be the range of hyperkalemia in this patient. Okay, Moderate means 7 to 7.5, and severe is more than 7.5 to 8. Okay, and very severe is more than 8. That is the severity of hyperkalemia. Okay, we have seen tall T waves. Now we will see whether there is, now we will calculate the rate. What is that? This is the QRS complex. Okay, from here to here we will calculate the rate. Rhythm is regular. See, the rhythm is regular. RR intervals are regular. The rhythm is regular. So we will calculate by 300 by large boxes. Okay, so approximately there are three boxes. So 300 divided by 3 by 100. So it is 100 beats per minute. So this is one more method is 1500 divided by number of small boxes, which I have forgotten to tell you. So if you take, this is 10, 3 and 13. So it is approximately 13. So 10, 13 za, 10, 1, 11 za you can take. So approximately some from 100 to 110 is the ventricular rate here. So it is regular. Now we will see whether there is some conduction disturbances. Okay, every ECG we are writing step by step, so that it is copy pasted in the mind. Okay, everything we are seeing. So you can see positive QRS complex, positive QRS complex, positive QRS complex. So that means there is no axis deviation. Okay, there is no axis deviation. Now whether there is any chamber abnormality, so left atrial hypertrophy, whether it is there or not. So for that you take V1 plus V5 or V6, no. So if you take here maximum, so this is approximately 7 mm, and this is approximately 4 plus 5 is 9, 9 plus 4 is 13 mm. So 13 plus 7 is 20 mm. But so the Sokolow-Lyon criteria is not fulfilled here. Now we'll see by the Cornell criteria. AVL you see it is 1 mm. Okay, now V3 you see how much, there is no R wave only in V3. So Cornell criteria is also not fulfilled. So chamber abnormalities as such we are not able to see. See the P waves. P waves are not widened and not heighted also. So that means, and in V1 also you see. So in V1 also you are not able to, yes you can make only a monophasic wave, but it is not more than one small square. It should be more than one small square. Then you can see, say it is right atrial hypertrophy. See here, I will show you. You are seeing as a monophasic wave, but it is not more than one small square height. Okay, so that means there is no chamber abnormalities. But see the R wave progression we have learned yesterday. The R wave progression is poor. See, in V3, if it is less than or equal to 3 mm R wave amplitude, then it is called as R wave progression. There is no R wave only here. That means there is poor R wave progression. So what are the causes of poor R wave progression? Number one is previous sorry. So number one is previous anteroseptal MI. Okay, I will tell you what it is. Number two is a left ventricular hypertrophy. Number three is lead misplacement. So lead misplacement is not possible in this because AVR is okay. So either the possibility is LVH or previous CSMI. Now you see here, this is a QS pattern, long Q and S. So this is a pathological Q wave actually. The Q wave is merged with S wave. So possibly this may be an ECG of a person who had an previous anteroseptal infarction. Okay, because there is poor RV progression. So that's how you should rule out. So it can be an ECG of previous anteroseptal myocardial infarction. Hyperkalemia is definitely there. Okay, so that's we have ruled out. But though there is no Q waves are there. So the Q wave signifies previous MI. So what can be the duration? So weeks to months. So it is in weeks to months. Okay, that's the duration. So these all things we have seen in this ECG. Now coming to this ECG now. So you can see here this T wave, V2, V3, V4, V5, V6. Okay, AVL you see and 1 you see. Okay, so these are tall T waves. I will just, so in precordial there should be more than 10 mm, no, at least 10 mm. So if you take it from here, So approximately they are 10 mm. You can't say. It looks like 9 mm. So they are approximately 10 mm. But you see the base is broad. Base is broad. The base is broad in precordial leads. In limb leads, in limb leads, the T wave should be more than at least 5 mm. Okay. So if you draw a line from here, from this side to this side, it is approximately 4 to 5 mm, and the base is broad. Now you see the leads. See the leads. Which leads are involved? It is one AVL, V2, V3, V4, V5, V6. It is anteroseptal hyperacute AI MI. Sorry, anteroseptal hyperacute MI. Okay. How you confirm that? You see the inferior leads. See here, there is ST segment depression in the 3 leads and in 2 and AVF also. So that confirms that is anteroseptal hyperacute myocardial infarction. Okay. So that you got to know from here. So there is poor RWave progression definitely here, and the RR intervals are regular. P waves are present, so it is sinus rhythm, and the heart rate is approximately 100 to 110 per minute. Okay, if you calculate. So that's about this ECG. So this ECG of is anteroseptal hyperacute MI. Okay, and this is hyperkalemic previous anteroseptal MI, which is confirmed by the QS pattern and absence poor RWave progression. Okay, the upside ECG. Now we will move on to this ECG. More ECG we see, more we learn. Okay, so you are seeing inverted T waves. Gross, if you see as a whole, you are seeing inverted T waves, symmetrical, and the two symmetrical inverted T waves here, here, here. So from V1 to V6, you are seeing symmetrical T waves. So, but there is no associated ST segment elevation or depression here. This is asymmetrical actually. See, these limbs are asymmetrical. Okay, these are symmetrical. This one, and these two, V2 and V3. Okay, these are symmetrical, but there is no associated ST segment deviation. But you see, the R wave amplitude is very much high. So that is, this is an ECG of hypertrophic cardiomyopathy, and these are the T waves of hypertrophic cardiomyopathy. Okay, hypertrophic cardiomyopathy. So if you see again here, there is no axis deviation, positive, positive, positive. Okay, and if there is, whether there is any hypertrophy, so right ventricular hypertrophy can we see? Yes, you can see right ventricular hypertrophy. See here, it is the R wave is approximately equal to 10 mm, which is more than 6 mm. So that is one criteria, no? So there is right ventricular hypertrophy. Okay, there is right ventricular hypertrophy. Chamber amount is there. Right ventricular hypertrophy is there. See the P waves in the lead 2. They are bifid. Oh, see here, they are bifid actually. I will show you. See, P waves are bifid. That means P mitral is present. That means there is left atrial abnormality also. There is left atrial abnormality also. We will see V1. What is V1? So in V1, you are not able to see. You are seeing a positive wave like thing. Okay, but it is not more than 1 mm. So what all you have find in this? So you have found first number is hypertrophic cardiomyopathy. Number 2 is there is right ventricular hypertrophy. Number 3 is there is P mitral. Okay, and this is in sinus rhythm. There is no axis deviation, and heart rate is approximately, if we calculate, 1, 2, 3, 4, and 5, 5.5, 5.5, 600, 5 ones are 5, 120 beats per minute is the heart rate. Okay, and these are the findings in this. Now in this way, you should send this patient for echo, 2D echo, and angiography and all. Okay, important these patients. Okay, so that all we have seen in that ECG. Now we will come to one more ECG, this ECG. Okay, this is all about T waves, which the theory of which we have discussed in the previous video. Okay, in this ECG again you can see T wave, very gigantic T waves, you can say gigantic inverted symmetrical T waves, but they are not associated with any ST segment deviation. Gigantic T waves you are seeing from V2 to V6 in the pre chest leads. Gigantic T waves. Okay, what is the rhythm? Rhythm is regular. Okay, rhythm is regular, and 1, 2, 3, 4, 5. 5 means 60, and there is bradycardia. Oh, one word I will say here. Okay, there is bradycardia, and the bradycardia, whether it is sinus, P waves are present. Yes, they are sinus, and the PR interval is shortened. You can see here. So PR interval is shortened. There is bradycardia, and the bradycardia is sinus because in 1 and 2, lead 1 and 2, P waves are positive, and you can see gigantic T waves, and there is poor R wave progression also. See this R wave. This R wave is approximately equal to 3 mm. Okay, in lead 3. So there is poor R wave progression also. So what and all we have found here is, number one, the heart rate is 60 beats per minute with sinus bradycardia. Okay, sinus bradycardia, I will say this as. Any chamber hypertrophy? So corneal criteria, this is 5 mm. That does not fulfill. Okay, corneal criteria doesn't fulfill here. Okay, there is no chamber abnormalities. P wave is also normal. There is axis deviation. See, one, this one, and this one also. Along with that, you see here there is left axis deviation, and there is QR pattern in 1 and AVL. That means there is left anterior hemifascicular block. Left anterior hemifascicular block. So many things we have found it here. So conduction abnormalities, there is present left anterior fascicular block is present. Number 2. Number 3. Okay, what we have found? Number 3, there are 60 beats per minute. Okay, these gigantic waves are nothing but the cerebral T waves. Okay, cerebral T waves. We have found the cerebral T waves. Just same to that. See, the it is approximately 15 mm in height, 15 to 16 mm. So very much gigantic. Okay, but remember, in T wave, whenever you see a symmetric inverted T wave, you just send, if the patient has symptoms. If the patient has symptoms, just send for troponins to rule out infarction, because we don't want to miss infarction. May it be any type of T wave. If they are symmetric and they are inverted, and the patient is symptomatic, he has chest pain or epigastric pain, something like that, or arm pain, you just send for troponins to rule out infarction. This all I am discussing just to know, know that these all findings can be there. If you found that troponins are normal, then you can decide, oh, that it can be some other thing other than myocardial infarction and pericarditis. Remember, in pericarditis also the troponins are elevated, but there will be diffuse ST segment elevation there. Okay, and PR depressions. So the takeaway point is, T waves are different types of T waves are there. But whenever you see a symmetrically inverted T wave and the patient when this patient is symptomatic, just send for troponins to rule out MI. We don't want to miss MI. Okay, so there are cerebral T wave inversions here. We have found. Okay, then there is poor R wave progression. Poor R wave progression. Okay, but there is no QS pattern as such. You can see here. Okay, poor RV progression is there. Probably they can be hypertrophy in this patient. Okay, so why there is sinus bradycardia? Okay, now we have known that it is a cerebral T wave. Sinus bradycardia is, the Cushing strand. No, whenever there is Cushing strand, just remember, whenever there is increased intracranial pressure, there will be bradycardia and hypertension. And one more thing is there. I am forgetting that 3 criteria are there for Cushing strand. Number 1 is bradycardia. Number 2 is hypertension patient will have. Number 3, one more thing is there. Okay, so that's why you are seeing a sinus bradycardia. Maybe the patient is having an increased intracranial pressure, maybe some hemorrhage, or maybe some mass effect due to ischemia in the central nervous system may be there. That's why there is sinus bradycardia. Okay, and you are seeing a cerebral T waves in 30%, as we have discussed yesterday. In 30% of hemorrhagic patients, you will find this. Probably this patient is having intracerebral hemorrhage. Okay, so those all things we have seen in this ECG. Many things. Now we will move on. So till now we have discussed the T waves now. Okay, whether we should quit and we discuss these things in the next class. Okay, I think it is enough for now. We will discuss the further things in the next class, and next class will be T waves are finished. Next will be different types of myocardial infarction, pathological Q waves, and the changes and with examples, and poor RV progression and differential diagnosis of acceleration. Everything will be there. We'll discuss in the next class. Okay. Thank you.